Welcome everyone to NEMA's Virtual Learning Lab. I am Jessica Bursky, NEMA's Senior Policy Analyst. Thank you for joining us on the start of the final week of this series. This has been an incredible learning opportunity for all of us, and believe me, the Buffalo Computer Graphics team will keep the momentum going. So today's session on lessons learned from managing points of distribution during this COVID response is very timely. And it is my pleasure to introduce Brian Head, Executive Director of Services for Buffalo Computer Graphics, to get us started. Thank you, Brian.
Jessica, thank you so much today, and thank you to all the participants, and especially to all of the NEMA staff that have made this possible. This is such a great opportunity for the group of us to get together and share information, network, and really hear a lot of voices that we might not traditionally hear, especially during this difficult time. So we really hope that out of this presentation, there are some takeaways that are value added. We really would appreciate, and I'd echo Jessica's comments on the survey, that only helps us and our panel get better when we do these types of events. And again, as this is a timely discussion, some of our panel, as well as our participants today, we know that your schedules are very tight and you've got a lot going on. So again, can't thank everyone enough, from the panel to the participants, in joining us. And we hope that it becomes, as we go through this next 90 minutes, an interactive discussion where we can communicate back and forth. We can learn just as much from our participants today as some of the takeaways that we will have on the panel. I'm going to let our panelists do a very quick introduction. I'll start with Tim Masterson, and then we'll go to Chris and Paul and Mike. Just to let you know a little bit about themselves, their background. Again, these are really some fine individuals when it comes to some of the topics that you'll hear today, some of the instances and kind of some of those war stories that they've been through that they'll be able to offer with their insight. So Tim, I'll turn it over to you for a quick introduction. We'll go through the panel and then we'll get started.
Thanks, Brian. My name's Tim Masterson. I'm the Director of Products for Buffalo Computer Graphics. I've had about 20 years on the team, everything from developer to project manager to tester to sales team, really working with customers to try to build technology around their needs. Sometimes that might mean new software products, sometimes that might be things that BCG builds, sometimes that might mean third-party products, with the idea being that we want to try to solve problems. So I've deployed at a number of FEMA activations. I've been out to Puerto Rico with Chris, who's on the panel next. I've also done a lot of work with New York State with Brian when he was former Deputy Director of Operations at New York State. So we've brought a lot of ideas together, from things that help warning points, things that help operation centers, things that help staging areas and pods, to really help give you some idea with regards to how technology was challenged and how technology helped as a part of pods. Chris?
Good afternoon, everybody. My name is Chris Breitbach. I am currently the Emergency Management Director for Allina Health, which is based in Minneapolis, Minnesota. My experience is both in emergency management and public safety. I spent many years in the emergency medical services field, and I'm a retired fire chief. In addition to my work at Allina, I'm currently the Deputy Commander for the Minnesota One All Hazard Incident Management Team, and also the Deputy Team Leader for the Minnesota One Disaster Medical Assistance Team, which is part of HHS. Like many of the other folks on the panel, a lot of operational experience. Started off in the early 2000s with DMAT, have been deployed to about 12 to 15 major hurricanes across the country, some wildfires, and other types of public safety events. So happy to be here. Thank you.
Thanks, Chris. Paul?
I'm Paul Crow. I am Assistant Director for Tomorrow Health, another one of the health systems based out of Minneapolis, and we all work very closely across health systems in the Twin Cities. First with medication management as COVID with rural out in the treatment, and then now recently I led the vaccine effort rollouts for North Health and created the representative for a consortium of the Denmark that helps support COVID vaccine rollout, and we're very closely with our regional health coalitions on tracking of plans on vaccine. So to make sure we're getting the right people at the right time. I'm excited to hear what some measures that we've learned over this last year.
Thanks, Paul. Mike?
And my name is Mike Walt. I'm one of the pharmacy managers at North Morea Health Hospital in Robbinsdale. Kind of pinch hitting for Paul since he's traveling right now, and we don't want to struggle too much with his audio. So hoping that I can fill in while he's on the road.
Thank you so much, Mike. We appreciate it. And yes, I did see some items in chat. We will, work with Mike and Paul. As we know, it's a busy time, and Paul's actually in transit. So, we'll work on that as we go through. So thank you to the panel for introducing themselves. At this point in time, we'll turn it over to Tim Masterson to start his presentation. When Tim's presentation is done, we'll have a little bit of time for Q&A, and we've also saved some time at the end of the panel discussion for some Q&A as well. So feel free to write in those chats. We'll be monitoring that and getting your questions in if you want to do those in line with the presentation as well. So thank you, Tim.
Thanks, Brian. So my goal is really to help give you guys at least an idea of maybe some of the technological challenges that we faced with regards to, standing up points of distribution, taking those pods and, switching them from what was really, in many cases, a staging point for PPE early in the COVID days to, really, areas where now we're doing, vaccination. So many of these sites, turned over quite a few times, how that, changed, from the beginning of the vaccination effort to now. There's been a lot of, directives that have changed. Obviously, there's been a new administration that's come in with some changes that happened there. There's been a lot of different recommendations from various states. So all of these brought, different challenges for these sites to really, get to work in the business of, getting vaccine out to the population. So I'm going to address it from the technical side, and then Chris will look at it from really the deployment side of some of the staffing and management of these sites. And then when we get into the third presentation, Paul and Mike will look at it from a pharmacological perspective, looking at, some of the challenges of getting, the vaccine to these locations. So really a lot of this began for us, as I mentioned, really at the start, as there was, demands for PPE, there was, obviously hospitals that needed, masks and gowns. There were sites that needed equipment in order to, deal with the influx of patients. This is really where we began to learn a lot of our lessons that we carried forward with pods. Really, it was a lot of the same types of things, as we stood up a new site for distribution, we needed masks, we needed any sorts of equipment that we might need for sanitizing that facility. We needed signage. We needed, things that would, really help direct people that are very often coming into, a foreign world, both the workers that are coming in, the staff that are coming in, the patients, the people that are coming in for the vaccine. All of this was very new to a lot of people, even though we might have, practiced this before or had, chances to maybe exercise with H1N1 or smallpox and the SNS distributions a few years ago. It really, became something new for a lot of us. So we needed a good way to stand a lot of this up and make sure that, as we stood up a brand new site, that we got them the inventory they needed to begin that site, that we could track those resources day to day, that we could find a way to try to get ahead of the resource curve, because especially in the beginning where the vaccine supply was short and maybe only a few days worth of supply on hand. What we really wanted to try to avoid was cancellations of people's registrations to receive the vaccine, because that just stacked everything up with regards to which days we had available. And then obviously we stood up web pages, and those would have difficulties with people that might not have the ability to access that technology or weren't familiar with it, or places. I know there were cases where sites were overwhelmed. So there's a lot of things that we needed to get these sites up and running. So the very first thing that we really identified for these sites is we needed a quick easy form that we could develop, that they could report what they had day to day, really get the word out with regards to what they might have had projected for usage of the various types of supplies on hand. And this really became the driver for what we had done both with PPE in the beginning, and then with the pods as we were standing up with a lot of the same types of equipment. From there, it's really getting that picture out to people. We're doing data collection on mobile terminals. We were doing it through web pages. We were doing it through other types of devices like phones and tablets. But we really needed to be able to craft a picture of exactly what was going on, what's being requested where, how much supply do we have on hand in various stockpiles. How do we communicate that to the policymakers so that maybe we could redirect some people to different areas? How do we get that information out to logistics teams so that they could begin to move stuff from different staging areas? So we did a lot of work with ArcGIS Online and a lot of the tools that Esri has to start building dashboards. And some of this was data coming out of our BCG system. Some of this was stuff coming out of third-party systems, such as asset tracking systems. Basically starting to find ways to fuse this information together so that we could communicate it in different ways. And Johns Hopkins kind of showed the way with a lot of the stuff they were doing in the beginning of the incident, with showing COVID numbers and infections, and the great work they did in ArcGIS dashboards. So a lot of companies like us really began to look at that as another tool for how can we extend incident management tools, inventory tools, CAD systems, other types of data out, so we could really bring a picture out to people to let them see what was going on at these pod sites. This is another example. Brian, you do a lot of work with the fire chiefs. You want to talk a little bit about this slide?
Yeah, sure. I definitely think that when we look at some of the associations, whether it be fire, EMS, law enforcement across the country, many of the associations have been able to pull together information from their membership and the communities that they serve. And this is just one example from the International Association of Fire Chiefs, where they went out and looked at, some of the different agency requests that were out there, as well as they've done boards and updated status boards on membership that have been infected by COVID. Again, when you look at the situational awareness and you look at resource management and being able to assign out these, different, key resources, and in many cases, resources that were in a short supply or that were limited, this is just another great way that, these different groups have been able to visualize that data, identify those areas of need, and can really become a tool in our own planning and emergency management when we look at, some of the resources that are available, or, some of those populations that we need to reinforce and assist. So, just other ways that, we felt when it came to pods and setting these up, that this was some great information from other sources that maybe individuals were not aware of.
Thanks, Brian. So really the next challenge for us was really identifying where these pod sites were going to be. In the beginning days for a lot of this stuff, obviously things were happening at hospitals and nursing homes and warehouses to triage stuff. And we'd already had plenty of plans in place for where we wanted to put cooling centers and, warming centers and areas for, evacuation and sheltering from other types of disasters. But we really had new challenges with regards to the vaccine distribution, because we might be dealing with people that are coming into the facility that might already have the infection. So obviously social distancing needs to come into play. Many of these facilities might not have been equipped with the space either for all the staff and equipment necessary for doing all of the vaccinations. Many of them might not have been located near the people that we, most wanted to get the vaccine to. So if we're looking at, our classical places where we'd already had, plans in place for facilities, we had to adapt those to start looking at, what other things might be available. Fortunately, with a lot of the lockdowns and, mitigation efforts at campuses and, people doing, remote schooling, that gave us some options that might not necessarily have been available in other situations with regards to being able to use some university and campus buildings, with using some arenas, with using some, entertainment and banquet halls. Unfortunate, the circumstances with why those are available, but in these particular cases, they help because they gave us some nice big areas where we could, really map out the facility, be able to bring in, the signage and the technology to keep everybody apart. So, we really needed to find ways to, better identify where these were, better identify where the populations were, so we could maybe, move these centers into these areas. And that's, again, where we tried to start leveraging technology. Just a few examples, as we started to work in projects, throughout the country, there was a lot of these that were looking at, vulnerable populations, looking at where do we have, a lot of maybe elderly or people that are over, 65 or 75, where obviously that brought a particular risk factor with regards to COVID. So, starting to move our distribution sites maybe closer to those areas so they don't have to drive as far, or so that they might be able to, either walk or get some other forms of transportation, mass transit to get there, as opposed to, making them come, maybe halfway across the city to where some of those other planned sites might have been. Here's another example of some of the ESRI risk mapping. There was a lot of great tools with this with regards to looking at some of the comorbidities as we started to do stuff with the healthcare, some of the healthcare systems that we had with, a number of hospitals that would share at least, where here's kind of the location, the general locations of where some of our at-risk populations were. So again, using some of that information to make some decisions early on as to where would we move, some of these pods and distribution areas. And then another great ESRI board that kind of shared with some of that Johns Hopkins information, looking at daily trends with regards to infections and new cases, per capita. So we could maybe start looking at, well, we're kind of on a down cycle in certain parts of the states. New York City is going high. Erie County was kind of low early on. Later on, that kind of flipped. The New York State was looking at Erie County and Western New York as an area that was really the hot spot for water, where everything was going on. So, where we put some of the focus for some of the pods, to start, assisting in that area, changed over from what we were looking at before down in the city. And then that really carried over to, after we've set up these facilities, how do we get the equipment to them? This becomes more of a daily need sort of variety. We can plan out some of it, obviously, because we know if, site A is using, 3,000 vaccines a day, they need a certain number per week. We can plan some of that out, but there's other shortages that happen, either, lots that, might have set out too long. So now we're down lower than we got. Certainly there's plenty of vaccine that might've been promised or ordered that didn't necessarily show up. There might've been other pieces of equipment that ran out. So we need to start looking at, how do we, resource, this information and give them a way to be able to share, what their needs are and quickly and effectively, handle those. So the requirements as we started switching from standing up these facilities to more of the day-to-day efforts, really began with, how do we, quickly respond to these requests, keeping in the back of our mind that, a lot of people are familiar with, email and, phone calls and a lot of things that kind of go untracked. So how could we use, technology to maybe help assist us with that, knowing that down the line, we might need to be able to go back for reimbursement. We might want to be able to look at the trends and what happened so we can try to plan for this better maybe in the future. Should something like this happen again? What site issues were we having, consistently, that, some mitigation at that site, better, walkways, expanded facilities might assist in some of our problems. It might have been, cold freezer storage, any sorts of refrigeration that we might need that might help with those sites in the future. So we wanted a way to electronically capture that so it wasn't lost. Anything that's going on onto paper is going to be very hard for us to do analysis on later on. So that became an area that we wanted to make sure that we took care of. We also wanted to efficiently, handle everything from the warehouses and the stockpiles back out to these pod sites, especially as they were changing. I know for us out here in Erie County, there's been new sites that have been stood up in different areas, very often. So that changes, the target, where we started with 2 or 3. Now there might be about 10 right now, and they've all got different needs. And then you take into account, some of those auxiliary sites, such as some of the things that are happening maybe at CVS and the Walmarts and the Walgreens. A lot of work there to make sure that all of this is being tracked and maintained. So what we did, and this is just an example of some of our tools, we really tried to put a piece in place where those pod sites could put in a request for what they needed. And alongside that, they could have that come into either the staging areas or the warehouses, those areas that were really responsible for managing those resources could take a look at what they had in the stockpile. They could look at moving that stuff out to the various sites. They would work through that day to day, use handheld scanners and other things to get that information out. So then this came to, well, what about the overall information on this? We're constantly being asked, well, how many vaccines, have we given? Where are we having problems? What's going on site to site? Some sites are having to be shut down because of, protests. Some are being shut down because of vaccine supply and cancellations. Some are being shut down due to weather and other things that, are moving around the world around us, that we are going to keep going throughout the rest of this year as we keep going down this effort, as we have hurricanes and mudslides and floods and other things are going to happen as the seasons change here. So how do we stay on top of this from a situational perspective so we can look at what's coming down the line, help use that for planning to help make sure that our vaccination effort continues to move forward and doesn't get put on pause for a while we have to deal with some of these other things. So what tools can we use? What data can we pull from multiple data sources so we can begin to do this planning around this to help make sure that we stay stable in this area? While we're doing that analysis, we need to be able to communicate that information to those people that are making decisions, whether that's the people back at the emergency management staff or at the healthcare clinics or at the executive level that are setting policy and different decisions with regards to maybe lockdowns or things that we're doing at various sites. This is all stuff that we need this situational information so they can help make those decisions. And then ultimately, do this as efficiently as possible so we can vaccinate as many people as possible. So what we started doing was pulling from, again, leveraging ArcGIS. There's a lot of other data sources out there with regards to weather and fire information and flood information, pulling that information into a common operational picture viewer so that we can fuse that data together and, people that are kind of outside of the full, pod day-to-day management can start looking downstream at what's coming and how that might impact operations. Starting to look at your tools like your web EOCs, your disaster lands, your knowledge centers, trying to bring that information together into your incident management platform so that you can use that to start making decisions both about this, COVID incident that's going to be ongoing, for, the extended future as far as we can kind of see right now, as well as other things pop up with regards to, hurricanes and floods and other things that obviously are going to impact us at an EOC operational level, where we're going to still have to be using resources, still be making decisions to protect the public and our populations while this, is all ongoing. We leveraged a lot of ArcGIS boards again this way, both to bring data out of disaster land, out into these tools to pull data from other state systems. Again, those same names, the Web EOCs, the knowledge centers, the NC4s, bring that data together and fuse together from multiple disparate systems, CAD systems and whatnot that was going on, to take a look at both what's going on at the pods and some of the situational information that's around them. So this is just an example on the boards that we use more around, the pod activity and situation versus this other one is more general situational awareness. But the two of these really tie together with, making sure that we can move forward effectively. And then finally, starting to take advantage of some of those other technological resources that are out there, streaming video cameras that might be on campus. And since campuses are really, where a lot of our staging, where a lot of our pods, a lot of our warehousing is happening, starting to be able to look at those campuses to see if there's, traffic that might be impacting them. Sometimes there's, protest or civil disturbance going on where we might need to, reevaluate, maybe where the entrances are for the pod facility to, make sure that we can keep those operations running, or a particular facility gets impacted by, any sort of, weather or other sort of event that might be going on where we might need to adapt and move on. So these camera systems right now are really deployed all over the place, from highways to schools to other buildings. So how do you bring, that IP-based video technology together, allow these pod sites to keep track of this, both in terms of awareness for them, in terms of what's going on day to day, and then awareness from more of an executive level for all the pods to where we might be having problems as well. So this was an area where we really did, a lot of focus, bringing some of these other tools, third-party tools and systems together for some of our customers. So some of the challenges and things that we still, are working through both now and as we move forward, how do we train staff quickly to this? Obviously, with COVID, we had to go remote for a lot of things. That was good in a lot of ways, because a lot of these tools that maybe have been sitting on the side for a while, that were getting used, more when we had the big one hit. Now we've got a big one that hit really for months, and now at this point, a year on end. So, how do we train staff quickly on these? How do we begin to, tweak those systems and adapt them and train the people on the changes that we made so that they can utilize those quickly? We did a lot of work with quick reference guides, short little documents, short little videos, a lot of success in doing training that way, especially when we're talking about doctors and nurses and, physicians that are working at these clinics. We don't have a lot of time to bring them all together to do long winded training sessions. So, breaking those trainings up into snippets that they could easily consume, became something that we really began to do a lot of, and we were very successful with. Obviously, there was a lot of regulatory challenges. Both between the changes from one administration to the next, the changes from state to state, the changes often within the state from day to day as different populations were targeted for vaccination efforts, and adapting to those. We saw a lot of things early on with people traveling from one state to another in order to try to get the vaccination. We saw a lot of issues with regards to quarantines and travel associated with that, and how do we track that? What forms do we need in place for that? And again, all of these changes became, electronic changes for us for new form fields, new types of ways to track that information. How do we train people on those changes? Another challenge that we had to look at there. Obviously, a lot of technological difficulties. We all know that technology can fail. It's not always the systems that are failing. Sometimes it's the in-between that doesn't work. Some of the sites we picked, didn't have great connectivity to start with. Either they didn't have great internet connectivity to start with, or they're kind of in an urban canyon where, cell phones and other things might not have worked there. So it really didn't give us a great, wireless tool in that area. So if that site didn't have great internet connectivity to begin with, and you can't bring in, cell phones and have that kind of fill the gap, what types of tools can we use that kind of work in an offline, mode that allow us to, capture the data we need and then transmit it, later on when they can, get Wi-Fi somewhere else. That was something we had to look at. Obviously, from the sign up side, there's people that are beginning to use websites to sign up, for the registrations for the vaccine. and those sites can get overwhelmed and crash. So how do we load balance those servers? How do we expand the capacity there so that we can do more with more people more quickly and be responsive to that? There was a lot of changes that happened with regards to the servers and the technology from the back end to help deal with this as we move on. Very often there's a lack of know-how on this, both from the population side, the mass population of, well, how do I even use these tools to sign up? Where do I go for this? How do we communicate to them? All the way up to the staff side, how do we communicate the changes and where everything is, especially when we're drawing on a lot of volunteers to make sure that these pods run. Tracking into the future. We talked about this a little bit earlier as we're looking at the paper process, and everything that's on paper is obviously tracked, but what happens if we want to go back to those records later on? That's a very costly endeavor to analyze all that documentation, versus if we can find a way to either track it in parallel electronically, or if we can start tracking that right from the get-go in some sort of system that's maybe printing out a paper copy that we can work with as well. How do we bring that technology together so that we can really have both, because in many cases we're mandated to maintain a paper copy. So how can we have an electronic form that does both of those sides for us? Obviously, we're continuing to look at the logistics side. As this changes and adapts, and there's new mandates for different populations that are going to be allowed to get the vaccine now. How do we most efficiently move and store the equipment and the supplies that we need for all these pods? And again, how can we do that from a technological standpoint? What can we do with the tools to start developing ways to track this stuff so we can make better decisions, not just now, but moving forward if we have something like this happen again. And then maybe one of the biggest ones, especially as we moved out of the we're just tracking supplies and PPE, where this is really just for hospitals, and obviously there's some confidentiality there, but there's not patient data associated with it. What happens when we bring in patient data associated with this? And some of these systems, even if the system themselves is compliant with HIPAA, that might not be compliant on a individual customer by customer level. There might not be a business associate agreement signed in between to help protect the data. There might not be the software in the back end in place if we're dealing with on-premises solutions or even some of the cloud solutions out there. So as we start moving these tools that were really designed for an incident into more of these daily use pod management tools, how do we make sure that we get that security in place, the tracking in place, the auditing in place, to make sure that tool is going to keep us in compliance here, and that we're not running afoul of anything there. So these became challenges that we had to work through, and certainly there's a lot more that can be done in all these areas as we continue to move forward in this and get this vaccination effort moves into the summer and into the fall and going forward. So with that, I'll open it up to questions, and then we'll move forward to Chris.
Yeah, thank you very much, Tim. So if anybody has any questions, feel free to enter any of that information in chat, and I'll pass those along to Tim. While we're waiting for some of those questions to come in before we hand it off to Chris, Tim, one thing that I would like to ask you maybe to expand on is there are so many different visualization tools out there, and you covered quite a few of them in your presentation, but again, there just seems to be a plethora of ways to get that data, into some format that different organizations, different, entities are using. Can you help explain maybe the difference between a visualization tool versus tools to actually manage the data? And I think sometimes, we get lost in that, where we kind of get that picture that we need to make critical decisions, but sometimes that picture doesn't necessarily, allow us to manage the data, to move the data, to assign the data. So I just, again, while I'm going through chat, just thought maybe you could expand on that.
Sure. So it's a great question. So especially with COVID, and I was going through some of the slides, a lot of those things were quick stand-up things. What can we get that's really fast and get that out? as soon as possible, because, we very often we didn't have a whole lot of, time frame to plan for this, or even if we did, we were already inundated with things that we were doing for managing, PPE, managing, the infections, managing the hospitals, and now we have vaccines on top of this. Oh my goodness, we need to come up with something really fast. So there's a lot of great tools that were really developed on the fly with things like, Survey 123 and some of the forms there, Fulcrum, and some of the great tools they had for building electronic forms. I even saw people using things like SurveyMonkey and Google Docs to get things that would be shipped up that way. And then building, a lot of those tools of export, that can go out to other tools that really help to model that and, give you charts and graphs to give you some information on it. So you can see a lot of things like Tableau with regards to charts and graphs. You can see a lot of nice stuff out of the Esri tools. Obviously, I had some screenshots of that. So that became like a great way to really get that stuff out and visualize. The problem that we saw, and we're still seeing it today, is so many of these things are very disparate. There's 5, 6, 7, 8 different tools that all these groups are using. They don't really tie together. So at the end of the day, there's not one common place to really get that information, be able to say, hey, that's where we go for our incident record because we've got it now spread all over the place. The other problem with it is very often a lot of those tools are really designed to be, a form submission tool. So they're designed to let you develop a form very quickly and get it out to people. But what's the process behind that afterwards? When that form's submitted, how do you move it from point A to point B in the process of assigning it to other staff members that you work with? For some of the other tools like Disasterland, the WebEOCs, the Noggins, things like that, wrap a process around that so that you can, begin to track that as you move it from, one group in the warehouse to the group that's at the clinic to the group that might be, transporting that equipment from site to site, and then putting, a full workflow around that. That's what I began to see as we moved from these quick and rapid tools to how do we make this more permanent? How do we, bring it into those larger incident management tools so that we could, really put an end-to-end, workflow around that.
Yeah, I think it's a great point. I think we all saw a lot of silos of information. We were kind of used to that. If you've worked in an EOC, sometimes you get silos of data that come through. And, again, how do you get that rapid, need for the information to come in, but that it's not an independent silo that you can't integrate or, bring into, working with interoperability, even other systems, so that you can build on that. Got some great questions in here. Another one, Tim, before we move to Chris, is based on some of the pod tracking that you showed off, question from Amy and Mike in regards to, is that system connected to an inventory system, and would it be linked to resource requests? So I think those are some good, again, you've got this pod tracking, but does it integrate, does it work with other areas to make sure, again, that it's kind of not a standalone, odd item or module?
Yeah, that's a great question. So with the tools that I kind of had in the screenshots there, at least the ones that are, from BCG, those tools were tied together. So as the resource requests came in, those got logged in the system in our ticketing module. That particular ticketing module has a tab associated directly with it to go right out to the inventory system and then track, what part of the inventory got associated with that resource request. It decremented the inventory from that warehouse, so that as we assign some resources to that resource request, it would automatically do the decrementing, would create the assignment for that, so that logistics knew what was being brought in from where, so that could be put on the truck for that. That actual resource at that point got tracked so that we could see, what status that was in. Is it being deployed? Is it on scene? Has it been delivered? So we can move on to the next request. And then all the information from that flowed into the pod tracking system with regards to the resource request side of it, for where are we getting requests, as well as where do we have the inventories going out. There was another piece of this that also went through the ticketing system. There was a form that the pods would submit each day to basically give a snapshot of where the inventories were and where they were projected to be the next day. So that information would flow in as well and could be viewed alongside and with the resource requests and everything else about that pod. So you could see, what's their current status, what are they immediately requesting today, and then where is that resource that we're going to be getting for them and sending it out to them.
Thanks, Tim. And one last question before we move over to Chris. Is the pod tracking that we're talking about here, some of those solutions that you've seen, do they also offer contact tracing, or have you seen where those have kind of been separate solutions? And again, it could even, I'll build on it, contact tracing or scheduling, right? We always talk, that's a huge piece when we're talking about pods as well. So have you seen those merge, Tim, or have those typically been separate systems that you've seen?
I've seen both cases. For instance, in the state of New York, the state deployed their own contact tracing tool, and that's where they want most of the contact tracing to flow through. So in many cases, it's become really an export out of some of the incident management systems in New York State, like the New York response system and some of the disaster plan systems in the counties and the web EOC systems at the counties to get some of that information up to it. But a lot of that contact tracing was really done more through that state, Department of Health system. That said, where I've seen a lot of the contact tracing actually, happening within an environment like this has actually been in some of the private sector. Some of the facilities like, the Verizons, the Geicos, and, the companies that have a large workforce are, really taking on a large effort of doing contact tracing themselves just within facilities so that they have a better idea on, which sites might need to close down for a bit, which ones might need to be cleaned, which ones might need to have some level of quarantine going on with some of their staff. I also saw this in some of the school systems that have tied in with it to do the same type of tracking that way, whether that's done through an electronic form where it's being sent out, through a Google Doc or a Survey 123 or a disaster land type form, out to, people that had become infected to get some information from them, or if it's being sent to an employee to get some of that information. That's where I saw a lot more of it happening with regards to, some of the solutions that I'm in charge of over in New York State. Brian, did you see any of that stuff with some of the other states and some of the other areas that we do some work in?
Yeah, absolutely. I think it's definitely a difference in some states are home rule states, some are not. Some states had the technology to be able to hand out to all the localities, so they utilized those common platforms, and others built those standalones, and then, sometimes, it integrated well, and sometimes there were challenges with integrating that data because essentially you had two parallel systems that are operating side by side, and then eventually they have to meet, right, and come together. And sometimes there's challenges, depending on if it's separate vendors or, even technology stacks. So, I think from that side, I would agree. It really depends on the location of where you are and those resources on hand.
All right, thank you.
Yeah, so Tim, at this point in time, I think we're going to move into Chris's presentation. I would like to say as we do that, a big thank you to Amy, Mike, Bruce, and Patty. Sometimes it's hard to get people to, ask that first question, and we really appreciate the interaction with you guys. And again, just a reminder to the participants, it doesn't have to be a question. You could be helping to share some of your stories that would be relevant and would be very, informative to the other panelists. So, feel free to share those war stories or share those, use cases with us. We appreciate the interaction. So at this time, I'll turn it over to Chris, and he'll give you a little bit of, his experiences, and we're really looking forward to it. So Chris, it's all yours.
All right, thank you, sir. Good afternoon, everybody. My name is Chris Breitbach. Like I mentioned earlier, my day job is I'm a System Emergency Management Director for Allina Health based out of Minneapolis, and my side gig is as a Deputy Commander. One of my side gigs is a Deputy Commander for the Minnesota 1 Disaster Medical Assistance Team. And what I want to talk to you guys about today is a recent mission that I commanded that we went to the support Quad City, Nevada Public Health and a vaccine mission. And just some of the experiences we had and some of the lessons learned. So next slide. So there's a lot of different ways that we can package our resources that go out the door. In this case, the team that I led, we went out as a health and medical task force, and The team is broken down here on the left-hand side of the screen. We had a safety officer. We had one provider who happened to be a physician assistant, one of our pharmacists who was also capable of administering vaccines. And then there's a little bit of variance of how many RNs versus paramedics you choose to do. And the reason why I point this out is at the same time we deployed, another DMAT team also deployed down to Las Vegas. And that was a full team operation of about 40 people. Their mission was very different and to support a large volume vaccine mission that was happening down in Las Vegas at the time. This was our two teams that went out were the first two teams that started to get into this type of work. And as we speak today, I was just looking at the sit rep that came out yesterday from the feds. And this mission continues in a variety of places across the country, both large and small teams supporting the work. So part of the objective of having a health and medical task force is we're small and we're mobile and we're more responsive and able to move around quickly. We did vaccine clinics at a variety of venues. You can see them listed here. There were senior centers, community centers. We were working in fairground pole barns, schools, in the gymnasium, outside the gymnasium, drive-up operations. There was a train museum we were at one day. So there was a wide variety of areas that we had to go and support the mission at. Our volumes, we were administering roughly 300 to upwards of 1,200 vaccines per day. We were not the only show in town doing this. Some days it was our DMAT team only administering the vaccines. Other days we were working with support of the National Guard with the state of Nevada, or other teams that were helping out. And I'll show those in a slide here in a few minutes. One thing that's most notable is I know a lot of people are aware is, the logistical storage and prep considerations differing between Moderna and Pfizer. The majority of our mission, we were working with the Moderna vaccine. We worked with Pfizer for a couple of days, and when this mission happened, the Johnson & Johnson had not come out on the market yet. Next slide. So again, a lot of the support that we had came from a lot of different areas. It was really nice that our mission was really clean and crisp. We were there to give vaccines. We did help support the build up and tear down of the vaccine stations every day with the locals. But there was a strong logistical support from a variety of different areas. Like I said, the Nevada National Guard both provided logistical support and medical support. Team Robicon was there again, providing us with some front-end logistical and administrative support to get the folks in the door, to get them registered. One of the big factors too was if it was a first vaccine or a second. The first vaccine happened a lot slower because there was a lot more paperwork that needed to be filled out. Can't say enough about the CERT teams. They were heavily utilized within this operation. And then we had some other federal partners as well. FEMA had boots on the ground helping us out from an administrative perspective. I understand just north of us, a ways in Reno, Nevada, there was AMR teams that were also doing vaccine work with the state out of there. So that can't say enough about the VOEDs and the additional support that we got throughout this mission. Next slide. These are just a couple of pictures. I apologize that HHS does require us to heavily scrutinize the pictures. I know my colleague, Carrie Rue, who's the Carson City Local Public Health Preparedness Program Manager, she was my right-hand person as we were working through this work. They were the entity or agency that requested us. Some of the slides that she'll provide will give you a little bit more context, but as you can see in both these slides, the left-hand slide was working at the train museum one day where we did a couple hundred people. On the right-hand side, although it's a pole barn type of operation at a fairground, that was probably our busiest day that we did over 1,000 with our 9 vaccinators. So that made for a very busy day. Next slide. One of my first questions I asked as we were preparing to deploy and working with Carrie and others was, what's your plan that you have together and that we're going to be walking into? I had done my homework and doing some vaccination work within my local healthcare system here and supporting our healthcare coalition in the state of Minnesota, I knew some of the complex nature of setting up these vaccine clinics, and walking into a different state. I wanted to have an idea what was happening or what we might be expected to do. I was really rest assured, and Carrie said we dusted off our closed pod plan. We changed a few words from flu vaccinations to COVID, and made a couple small modifications and pulled the trigger on it. And I really want to commend the locals for the work that they had did over the past several years. They had used this closed pod plan for the past 10 years in doing their flu vaccine clinic, and really worked out a lot of the bugs that had happened. And I think that that's one of the key successes to this mission being so successful, was that they had done this before. It wasn't something that they checked a box for a coalition or a state government, and never actually operationalized it, because over those 10 years, there was a lot of things that they changed, which we were able to avoid when the time really mattered. Next slide. So this is a slide that Carrie put together. Like I already mentioned, 10 years of this pod planning. They had worked in working with the school districts. They were able to really maximize this plan. The square area of a footprint that this Quad County Public Health is accountable for is pretty staggering. There was a lot of missions that were driving around multiple hours to get to these locations. And just like with a lot of agencies with minimal staff, they brought in a lot of retired folks and a lot of contract people to help out. But again, we were just one part of the larger puzzle that had been happening. The second to last bullet point down there on the bottom, like I said, I just want to also put a great shout out is my understanding is the Quad County Public Health is the fiscal agent for the Healthcare Coalition in that part of the state. And their partnerships and relationships that they had established for many, many years also was a key success to this mission. The local public safety emergency management, the local healthcare, they were all present at a lot of these vaccine clinics, and you could tell that there was a great relationships that have been built that really lowered the volume and the temperature of some of the anxiety that happens with some of these types of events that are happening. And then Carrie also points out some of the additional staffing that she got that I had mentioned earlier. Next slide, please. So this is a couple of pictures of that Carrie provided to us. This was a day that was at a community center that we were giving vaccines. On the left-hand side of the scene, you can see some of the DMAT team members and also some of the National Guard. I believe this day we did upwards of 800 or 900 vaccinations. This was a day that we were doing Pfizer. Up on the top of the picture, you'll see there's a table up there. We had our pharmacist and our physician assistant, they were drawing up the Pfizer vaccine to make sure that absolutely nothing was wasted and we were doing it correctly and so on and so forth. So great partnership and relationship had developed by this point. This was towards the end of our mission. On the right-hand side, as you all probably know, you have to wait for several minutes after your vaccine. So those are folks just waiting to be cleared to depart. Next slide. Like I mentioned, a couple more pictures on the left-hand side. This is outside of the Carson City High School, where we were working again with the National Guard to get people prioritized and move through. This was also a Pfizer day that we were working on. On the right-hand side is one of the more distant locations we went to, and working with the locals. And remember, at this time that we were in the 1B. The 1AC category and just starting to breach into 1B definition. So a lot of it was the 65 and older. They had just come out at that time with school teachers and people that worked in the education industry. So we were getting large boluses of both school teachers coming in and also the 65 and over population. Next slide. So these are, again, some notes from Carrie that she brought forward. Some of the kits did not provide enough needles. We were going through needles quite a lot. Luckily, the locals had stocked up previous to COVID happening. better to staff up than never to have enough people, just like anything else. You know, there were some times when you're dealing with a lot of different agencies and a lot of volunteers, sometimes people just aren't finding the right location or whatever. That could happen. So it was best to have more than not enough. I think that we kept everybody busy just about every day we were there. Technology is never your friend, as Tim just talked about. There's a lot of variables that have to do with technology. That was one of my concerns, was were we going to be embedded into some electronic medical record that we were going to have to understand, and all the nuances that come with that working in sometimes austere environments. We were happy to hear we were going completely low tech, and everything was pen and paper. They had already printed everything out. All of the registering had happened behind the scenes, and we did not have to manage any part of that. Again, that teamwork is the dream work. We really blended together, gelled together really well, and helped each other out. Other than the uniforms we were wearing that were different, everybody was there to do the same thing. The public information, as we all know, in the communications and coordination was a really big deal. They, again, hats off to the local public health for a lot of the work that they had done there. Having really clear, concise communication through the PIOs made it a lot easier, so the right people showed up at these vaccination stations, and people that did not meet the criteria were not coming in. So that really, again, dropped the temperature quite a bit from what we experienced. Next slide. So just kind of some overview of some of the questions that we received, or maybe some questions that you have. Obviously, the National Disaster Medical System, DMAT teams, is a federal program. We support those communities with medical care, veterinary care, and mortuary assistance. You know, almost a year ago to the day, our team was deployed to California to start taking people that were repatriated back to the United States off some of those cruise ships coming from China and Japan. We spent a lot of the summer, the DMAT teams, helping with hospital and healthcare decompression of patients as the COVID cases went up and down in different parts of the country. And then we transitioned into some of the BAM infusion therapy, and now our bread and butter right now is the vaccine clinics. And again, I just checked the sit reps out. We are in every corner of the country. DMAT teams helping support state and local assets with some of this vaccine work. We are available by the U.S. Department of Health and Human Services, ASPR, and that's how we get activated through the state and up to the federal level. Worked a lot in partnership with FEMA throughout this mission and many other missions that we've had over the years to get this exercise pulled off. This health and medical task force concept is relatively new to DMAT, where we're not sending these large teams out, and it's really proven to work well. We get the right people, the right number of people to support the state and local. It provides that flexibility to overall have success. And again, getting back to what Carrie mentions, that significant pre-planning by the local and state really helped increase the mission success that we experienced. I think this might be the next slide, but go ahead. All right, and with that, I will turn it back over to Brian and see if there's any other questions. Thank you.
Yeah, thank you so much, Chris. You know, very informative on a piece of, you know, that federal system that we don't hear, you know, a lot about, but is really, you know, a backbone to a lot of response across the country. As I open it up for questions into the chat, one question I'd have for you, Chris, is how would a jurisdiction or a healthcare system request a DMAT? And I think that's, you know, always good to kind of cover and highlight to make sure that we're following your process, you know, to make sure that, you know, again, if we need those, you know, pieces of assistance, that we're requesting it the right way.
Sure, I kind of alluded to it already, but you know, those kinds of requests will go up through your state emergency operations center with a signature by the state governor, and that will go up to the federal level. And Health and Human Services will take a look at that. There is some triaging that takes effect. We do have some advanced teams that go out, and a lot of times when there's a mission request, we will send out a safety officer and a clinical leader to go out and check out and work with the locals to understand what is the mission need, to make sure that the the mission is something that we're capable of executing successfully for both the locals and what we can bring in for support. Do we need more? Do we need less resources to come in? So those kinds of things will go up through your state emergency operations center, and then be decided upon at the federal level. Thanks.
Yeah, thank you. And one of the questions from the chat from Bruce and Patty, since so many DMAT resources are being pulled or utilized together for these vaccines and distribution areas, whether it be pods or whether it just be supporting some of the healthcare systems, how will this impact hurricane season when they're needed possibly in other parts of the country? Any thoughts on that, Chris?
Yeah, so that's part of what happens in that triage process is, you don't want to leave the cupboards bare per se. So the federal level is taking a very close look at that and making sure every month we have an average of 13 full teams that are on call. Every team has to be on call 3 times a year. So we do have backup teams that are available. The missions that we're executing now, helping out support the COVID, is both meeting the local needs, but also maintaining enough in air quotes reserve for the just in case type things that could happen. And as we look ahead into hurricane season, those kinds of things will be factored in as well. In addition to the 13 teams that are on call, there are other people that are happening behind the scenes to staff up additional teams. A lot of the DMAT members are also full-time healthcare workers or public safety workers. So to leave one job and take on another job, we've experienced this quite a bit over the year with COVID. A lot of people are double or sometimes triple counted at times. So they are paying very close attention to that and making sure that we are available to respond to the missions that are needed throughout the country and even throughout the world if necessary. So good question. Thank you.
Yeah, thank you, Chris, and thank you, Patty and Bruce. Chris, I think that just goes to, it's knowing and making sure we get all the details, when we make those requests, right? We want to get as much information about that mission, so again, when you're making those assessments, that helps in that decision-making and prioritization process. So, like with a lot of our resource requests, we're looking for the detail, to help with that. Okay, at this point in time, I want to thank Chris for his presentation. We'll loop back with him and Tim at the end here for some last-minute questions. But I'd like to turn the panel discussion over to Paul and Mike and let them give you some of their experiences that they've had and allow the participants to ask them some questions, related to their experiences. So, Mike, it's over to you. Take it away.
Yeah, thanks. Really, from our perspective, this was certainly a challenge from what we knew up front, which was to consider storage conditions that we were going to need to face. And then really, once we figured out those types of things, when we started getting our kits, we quickly realized, and Chris alluded to this already, that the supplies that we're getting to administer all of these doses, there might not actually be enough of those supplies to be able to administer the 6 doses out of the Pfizer or the 10 doses out of a Moderna vial. So pharmacies used to dealing with shortages, but maybe not so much on the supply side of things. So quickly pivoting to be able to figure out what types of supplies that we were going to need to track down, what combination of supplies was going to work to be able to extract the most out of each one of these vials that we could, and do it in a safe way. There's specific regulations on how long we can use sterile products for once we puncture them. And so being able to extract all of those things, use them within the time that we had allotted to, so that we can maximize the supply that we had. Outside of that, I don't have a lot prepared, and would be happy to field some questions on any of the pharmacy perspectives for this.
Yeah, absolutely. So Paul and Mike, one of the questions that I have here was what was one of the unexpected challenges that you faced with the vaccine rollout within your organization?
Yeah, and I alluded to that already with just the supply side of things. When we found out what vaccines we were getting, we spent a lot of time looking over the prepared materials that Pfizer and the FDA put out on the things that we could control, like storage conditions. But we weren't necessarily prepared for that sixth dose, because when the product was originally given emergency use authorization, we were only planning on 5 doses. That's all of the supplies that were being shipped out in these boxes. And I don't think it was sometime until February that what was being shipped out to us was enough to administer 6 doses. So a lot of scrambling to find supplies that we would be able to administer all of these. That was certainly a challenge for us. As our program to vaccinate grew beyond the walls of the hospitals, and we started doing community vaccinations, really that shifted, or we had to start thinking about who we were having prepare some of these vaccines. When it was centralized in the hospitals, we were able to have a little tighter control around who was preparing them. And now we were all of a sudden being given a larger group that we were training and making sure that they had the skills necessary to prepare these things safely and effectively. And that included using combinations of low dead space syringes as well as standard syringes to achieve those 6 doses out of each vial.
Absolutely. We even heard many in my own community, the hospital network, even was having a difficulty, sourcing gloves. I mean, again, when we talk about some of the things we've heard across the country with, first responders and healthcare workers getting the required PPE that they need, I know that was a challenge for them. I don't know out in your area if you saw that, or if maybe there was a government contract that was opened up for like an emergency standby contract for those types of resources, but I know that definitely stressed the system.
Yeah, definitely. Everything was on short supply. We were living through that prior to vaccines, just trying to get the supplies to care for patients on a day in and day out basis. And that certainly didn't go away by the time we got to the vaccine. Things like gloves certainly got easier to come across as things went along, and really the shortage became syringes and needles that we could use to extract all of these doses. Some of the other stuff that we were dealing with early on, masks and face shields, we had plenty of those going into this, but syringes, which I had never envisioned syringes being the thing that I was going to have to scramble to try to find, but that was the case that we found.
Yeah, absolutely. And as I look to the chat to some of the other questions, as far as logistics, anything that you can share, when you talk about that piece of it, or some of the efforts, with your interaction with Minnesota Department of Health.
Yeah, so I'll touch on 2 pieces for logistics, and then I can move on to the Department of Health. So once we started expanding beyond the walls of the hospital, again, we had to start considering where we had supply and starting to worry about transportation of vaccine. And what we knew about this vaccine from everything that was available to us, it was the Pfizer vaccine specifically, was pretty fragile. And so being able to ensure that we had all of the pieces in place to be able to safely transport vaccine between sites so that we had the appropriate number of doses available on the days that we were vaccinating at different locations, that certainly became a challenge. So that was an opportunity for us to incorporate students into our process. So using our pharmacy students as extenders, they were able to figure out some cold chain monitoring for us, as well as the appropriate packaging, so that we were able to safely move vaccines between sites. so that we could have enough of those at each one of the sites. From the Minnesota Department of Health standpoint, really they were the ones that were placing all of our orders and then allocating those out, at least at the beginning. So we would get information from MDH the week prior, and that's when we would figure out how many doses that we would be receiving. We took that information and put it into a supply and demand calculator that we had built. It would have been amazing to have some of the computer modeling that was presented earlier on in the presentation instead of my Excel spreadsheets that we were putting together. But we were able to use that to at least track what we had received and how many employees we had vaccinated, how many booster doses we still owed to other team members, so that we made sure that we had supply available to get through second doses. As we moved on into the community vaccination portion of this, the 10 largest health systems in the state formed a group that then was able to make recommendations to the state based on the total allocation that the state was going to get, how we would allocate that amongst those 10 largest groups, so that we would take vaccine based on the size of the population that we served within the state.
Excellent, thank you. One of the questions here, and I'm not sure, again, how much you communicate within some of the other pharmaceutical groups or some of the other associations, but did you, by any chance, one of the questions that came in was in relation to some of the shortage or supply with the winter storm that hit Texas? Knowing you guys are up north, were there any best practices that you heard of that came out of that, or in your own area? I know, you dealt with many storms over the last few months that have come through. Anything that you could say that, maybe there were some additional protective measures or monitoring of systems, to address any of those issues with natural disasters that could impact the rollout?
Yeah, it was certainly cause for concern with any delays that we would have. The goal for the state was to, within 7 days of receiving your vaccines, you would have used 90% or more of that. And so we're talking about really running things close from an inventory standpoint, where if you don't receive your shipment exactly on time, you would run into a situation where you might have to cancel appointments. And we were lucky to be in the position that we were in, that we could shuffle some things around. But had we not done some of that pre-work for vaccine transport, we would have been in a position where I would not have felt comfortable moving a vaccine that is as fragile as this one with standard methods and without some pretty good monitoring in place. So I guess have a plan to be able to shuffle things around within the inventory that you have. I know that as a state, we certainly were able to reach out to one another to shuffle some things around when needed. If someone had extra or if they needed some, we certainly worked together as a state to help accommodate that.
That's a great point. And I know from our side, we heard a lot of different groups, that ran into some of those issues, whether it be flooding issues, whether it be those winter storms where, backup generators were brought on site just in case, ensuring that fuel levels were topped off, and those types of preparedness activities that, again, you may not be doing day to day, but now because of, the limitations or the special requirements, may be needed in this setting, that typically you might not have, some of those aggressive, different vendor managed resources available during that time. So, okay, well, it was a great, discussion with you, Mike, and we appreciate Paul. I saw his update to everyone. So I think at this time, Tim, we'll roll it into a group discussion and just put it out. We've got a couple minutes left before I turn it back over to Jessica. So I'm going to go back. I've got one or two questions here that I'll throw out to the panel, and then just, again, opening it up to any of the folks that are online with any closing questions that you have. I'll make sure that we send those through. So, Tim, one of the items I would say, going back to technology, when we talk about data stability, I think that's something for decision makers, maybe we could have you highlight on. For example, I know, the Johns Hopkins board seemed to be one that everybody went to early on, but then there was so much traffic, that there just wasn't enough hardware, there wasn't enough bandwidth, and many times that site, was not functioning, or they would have to take it down to, do an update because they weren't able to in real time with the usage worldwide that site was getting hit. And I think, that's something when we talk about even those silos earlier, different data visualization sites may be using those different markers, different, database, sites that were around the country. And so sometimes those numbers weren't consistent. So you would look at one visualization site and it would say one thing, you'd look at another visualization site, you'd have different numbers. So maybe you could speak briefly to, the importance of data stability, whether it be from that hardware standpoint or maybe from, the standpoint of ensuring that you're all going to the same database to have the same information.
Sure. So you're definitely right. The scalability was probably when Chris said he was happy to be on a paper system, especially in the beginning for a lot of these things. If you were running an on-premises system, I saw this more than anywhere else. Very often it got overwhelmed right away because what we were planned for day to day, or even for a small emergency like I say small like a hurricane, the difference being that, it's small in terms of EOC perspective. This, COVID really, with the number of sites that were coming on, the number of users coming on from all these various sites, the number of people that might have been volunteers from various areas, really expanded what might have been, for, let's say, day-to-day operations at a normal, facility was 5 to 10 people, but then in a large, hurricane type endeavor, we're looking at, 200 to 300. Now we're talking about like 2,000, people or more. So for a lot of these systems, it just overwhelmed the on-premises solution. Things that we saw were successful there was, if you're on physical hardware, moving to virtualization, so you could scale up quicker, to have more systems and servers available to help handle that load. For places that didn't have the hardware available to run more virtual machines, moving that out into cloud platforms, whether that was AWS, Azure, some of the private clouds out there, like some of the places that we're in, like Lumen and CenturyLink, and some of those private cloud areas. That really allowed people to scale out with infrastructure. Esri did quite a bit on their end too. When we were working with a big provider like that, where they had, loads of infrastructure available, they could, scale things up very rapidly that way. So in many cases, places were able to be successful in keeping their internal operations small, maybe at like that 200 person level. And then when they needed to share data out to the 2,000 people or more, where they would, send that data up to one of those other, cloud platforms where all that additional hardware could be leveraged, where they could still run on their internal hardware, but move those operations externally that way. That was a trick that really worked very well to really help, broaden, what we had with capacity, very rapidly without, necessarily buying, servers to do all that stuff. So that's one thing that I saw. Some other stability stuff that I saw was, with those changing forms all the time, very often you'd see some of those front end systems that maybe we were connecting to going down quickly as people were updating stuff often in after hours. But, as people are basically waiting, clicking the refresh button nonstop to try to get their registration for a vaccine, they were seeing that as crashes and whatnot, because it was really a 24/7, solution that was up. So how do you set that up with multiple servers, or you can kind of roll out, that patch with those new forms, in stages, so that, people aren't seeing those errors, or less people are seeing those errors and can get in and get their registrations done. So, the timing of how you release stuff, how do you strategize around, putting out a patch which has to happen. We're doing new things, constantly. You got to get those updates out to those servers. So how do you do that in such a way that keeps it as stable as possible and the least number of people impacted? So those are a couple techniques I saw, but definitely stability was something that people needed to address during this, as we were really playing in many cases with these new solutions for the first time.
Thanks, Tim. And one last question I'll throw out to the panel, because I know we're getting close to our end, and I want to make sure that Jessica and NEMA have some time for some closing comments. But I'll throw out to Chris and Mike and Tim. We've got a question on here for daily reports. Were you guys used to, producing daily reports, in the instances, that you worked in? Were those tied to kind of those resource requests or the pod requests in any way? And again, throw it out that, whether that's from a mobile side, because I don't know if there's, some benefits and challenges with mobile data collection and reporting, or if that was kind of back in the office setting where, you would pull all the information together from the day and provide those various reports.
This is Chris. I'll just chime in quick. From the field side perspective, we were utilizing situation reports at reps to push a lot of our data up. It was, when you think back to the time in early February when vaccines were still, very important to hear on the daily national news what was happening. It was really, really important for us to be getting that information as accurate as we could from the local level all the way up to Washington, D.C. as quickly as possible. But again, it was very simplistic from our perspective.
I'd add on our end of things, there were a lot of requests for reports, and we wanted to make sure that the reports that we were putting together were things that would be actionable for folks, because like I mentioned at the beginning, most of it was me plugging information into a spreadsheet and pulling it from a number of different systems to get all of that information in. As we've moved along, we've been able to automate things quite a bit more in our electronic medical record, so that we can see things a little bit more in real time, but that certainly wasn't the case in the beginning.
Certainly from the DLAN side, one of the things that we saw people use a lot of, because we train with all the other incidents with situation reports, we train with all the other incidents with incident action plans. That's where we actually saw people have a lot of success with, was using those tools and bringing them into some sort of repeatable pattern. Now, with regards to incident action plans, with some of the cities that we work with down in like the Los Angeles area, they went to, kind of a once a week IEP to kind of get, some of that information moving forward for, what's going on for the next week is kind of a report, whereas their sit rep was really more of a daily report, and they would build templates around, some of that pod information. I don't know if I've got a great example without logging into their systems, which I don't want to do. But just as an example, one of our QA systems, they were using, some of the same stuff that you would normally use, your 202s, your safety plans. The safety plans probably had more than we've ever seen in them before. So, building those out so that you could get some of that messaging out that way, some of that pod data, back in there. And even if there wasn't a specific form dedicated to pods, bringing that information in as a part of the incident action plan was something that I saw, a lot of work done that way. I also saw a lot of reporting coming out of, some of those types of dashboards that people were working with, and using that as a segment of some of their situation reports or a segment of some of their IEPs to help draw some of that dashboard information in. That also very often had the effect of people asking, well, hey, you got that from somewhere in your report. Can I have access to that? So that helped to kind of spur that question. And then people would, get provided a login to that. They then were now on those incident management platforms, daily, using that as kind of a live, real-time report, as opposed to needing, to always get that situation report. So just the fact of including these components in some of those other reports helped to drive some of the people into these platforms so that they were using it more day to day, and it became a way to help drive some of that other situational information out there. So that was some of the techniques I saw that were really pretty effective in getting some of that detailed pod information out, was including it in those two traditional incident documents, and getting that out to the staff.
All right. Well, at this point in time, I just want to say thank you, Tim, and thank you, Chris and Paul and Mike from the panel. I'd also like to thank NEMA. It looks like we're out of questions. So, Jessica, I know we're going to turn it over to you. But again, a big thank you to the participants. I know when I started in emergency management, a wise person told me disasters start and end locally. And I see a lot of locals that are on the line today. And, we can't thank you enough for your information, the things you've shared with us today, the questions that you've asked, and hopefully as we go forward, everyone stays healthy and safe. So at this point in time, Jessica, we'll save the last couple minutes for anything that you may have that you want to cover. And again, a big thank you to NEMA for this opportunity, interacting with all of you, getting this opportunity to share some information. We hope some of these stories will inspire you and at least give you an ability to take away a few valuable points. So it's been a great platform and a great honor to speak with all of you. Jessica?
Yeah, and thank you, Brian, and thank you, Tim and Chris and Mike. And if you could give our gratitude to Paul, this has been a lot of information to digest, and we greatly appreciate your time as well.